Thanks so much, everyone, for being here today and for the invitation, Dr. Delmeister. I'm super happy to share my research with all of you. I am looking at a topic called telemedicine scheduling, optimization in surgical outpatient clinics. And as I mentioned before, my supervisors are Dr. Greg Berry, as well as Suzanne Morin in the Orthopedics and Internal Medicine Division. Just a bit of a background. As we all know, the pandemic has really introduced a new paradigm in Canadian healthcare, which presents quite a few challenges that have to be addressed in terms of accessibility and safety for patients as well as clinicians. In an initial study that we did, we found that 66% of consultations can be conducted via telemedicine safely. And we also found in some research that 96% of patients consider telemedicine to be as good or better than in-person consultations. We know that surgeons can wait a lot longer in the clinic due to restrictions of in-person limitations, and also that not all patients have access to telemedicine is something to keep in mind. In terms of safety, we know that for patients who have orthopedic injuries, waiting a long time in the waiting room can cause them pain and discomfort, as well as difficulties traveling to get to their appointment. And the use of PPE for long hours in the clinic for surgeons repeatedly can also lead to fatigue. So that brings me to my research question right now. And what I really wanted to look at is if the use of statistical models can optimize patient flow by using telemedicine in in surgical outpatient clinics. And so the first question I'm looking at is, will using a classification model lead to a reduction in unnecessary hospital visits? So I hypothesized that by identifying significant factors in a classification model that could drive the need for an in-person appointment, unnecessary hospital visits can be reduced. My second question is, I'm wondering if optimizing telemedicine scheduling template can result in increased satisfaction for patients and clinicians. And I've also hypothesized that satisfaction will increase in both groups with the reduction of waiting time and the overall efficiency of the system. So my two objectives that I am focusing on is first to establish the optimal mix of telemedicine and in-person consultations. And what that means is to classify patients as suitable or not suitable for a telemedicine consultation before the consultation takes place. And the second objective is to develop an optimal scheduling template for these telemedicine consultations. Developing personalized templates that are optimized for telemedicine clinics can be helpful to reduce that waiting time. And I'll be using lean engineering and simulation modeling to do that. So for the data in the patient population, I collected data from patients and surgeons, and that was through getting an REB ethics approval, and that was through questionnaires, and the data was collected by REDCap, as well as a HIPAA-compliant Google Workspace platform for the surgeon's end. And so I looked at different factors such as socioeconomic factors, telemedicine, access and usage, as well as some medical history questions. And then I also wanted to compare a pre and post satisfaction level for telemedicine consultations. And then as well for the surgeon, I looked at the complexity of the case to see if that would have an influence on the need for an in-person appointment, the outcome for an appointment. So that would be something, do they need to book surgery? Do they need an extra test? Has their problem been solved? Are they being referred to someone else, another clinician, anything like that? And then as well, next steps for the patient. So next step would be a virtual consult follow-up, an in-person follow-up, or the problem is solved. And then I also wanted to look at some other qualitative aspects, such as the quality of the consultation. So was this smooth for the surgeon, or was it a little bit bumpy with connection issues and things like that? And then as well, looking at the duration of how long the consultation took. So the inclusion and exclusion criteria that was focused on in this study were from patients who are 18 to 65 years old. We wanted to look at more of a homogeneous patient group just for the beginning of this and to have it be a bit smoother. And we did not include patients who don't speak English or French, and if they're not able to give informed consent, or in hospital patients. And so I collected about 50 data points per surgeon and had initially 5 surgeons, but 4 surgeons in total. And so all of that data would be input into the machine learning model. So the process of the data collection went something like this, where the surgeon would identify the suitable patients in the inclusion criteria. A research coordinator would contact the patients, explain the study, obtain consent. The patients would then conduct or fill out a pre-consultation questionnaire. And then the telemedicine consultation would take place with the surgeon, and it would be randomized to a video or a phone consultation. And then after that, the surgeon would fill out a short questionnaire. And then finally, the patients would receive a post-consultation questionnaire after the consultation. So looking at the first objective of telemedicine and in-person consultations and how to establish the optimal mix of the two, what I wanted to utilize is machine learning so that I could better predict if a patient should be seen in person or via telemedicine. I used a supervised learning approach, and that is because the surgeons would actually classify the data and the patients as being suitable or not suitable for a telemedicine consultation. And so with that, it would be helpful to determine these significant factors. And because the data set is a bit small, these types of algorithms would be useful in this sense. And so the algorithms that I wanted to test based on research that I've done in similar predictive binary prediction models are logistics regression, naive Bayes, decision tree, and support vector machine. And so then the end goal is to compare the accuracy of all these algorithms to see which ones would be best fit to be used in practice. And so to finally establish the optimal mix and classifying these patients as suitable or non-suitable, the variables that I was looking at were ones like age, gender, comorbidities, complexity of case, education, occupation, ethnicity and birth country, COVID-19 risk, and health status. And because these are quite a few factors, I used a factor analysis to see which variables are most significant, since the data set is quite small, before I do my machine learning modeling. And so for the second objective, so that is to develop personalized scheduling templates for the surgeons. So here I use discrete event simulation modeling, which is a low-cost way to test and compare different alternatives. And different distributions of what would be input into this model would be the tardiness of patients, no-show rates, consultation times at each appointment. So for example, a new patient would take longer than a follow-up patient, and a post-op patient would maybe take more time than a follow-up patient appointment, but less time than a new patient. And then as well, any time for external tests or activities. So next, to build these templates, lean engineering would be used. And what lean engineering does is it really minimizes the waiting time of the patients and the idle time of the surgeons by balancing that continuous flow of patients. And that's kind of based off of lean manufacturing, which is like a continuous flow. And so what I would need to use to construct these templates are the average consultation time, the percentage of appointment types. And so that would be figured out from the machine learning aspect and how we can predict how many patients should be seen via telemedicine. and then as well using the duration of each appointment and the time that's available to the surgeon. So in a November 2019 trial, this is what we did, where originally the distribution of appointments looked kind of like this. So as you can see, from 8 a.m. to 8:30, there are 12 patients booked in a 30-minute time frame, when on average they take about 7 minutes. So that means that patients would end up waiting, and what happens is the waiting time builds up throughout the day. But if we look over on the right here, all of these are balanced. There's still double booking because patients are often late. Sometimes a surgeon is late too, and different things are going on. So to level all of that would make it more efficient. And what we found in this trial is that waiting time was reduced by 65%, from 55 minutes on average to 19 minutes. So with this type of structure, I'm planning to use this in the telemedicine scheduling as well. And so just a quick overview of the process of how building those models will work is to first validate the distribution. So the pre-consultation time, the consultation time of the surgeon, any no-show rates, and then a current situation of the model will be developed with all those distributions, and then it will be validated to make sure it's an accurate representation of the system. Then the templates will be developed using lean engineering, and then those templates can be input into the simulation to determine if they are in fact successful, and then I can decide on which one is best for each surgeon. And so now for the analysis. So patients were enrolled in the study from March to July with about a 58% enrollment rate. So we enrolled 319 patients in total, and 186 fully completed all questionnaires. And we had 4 surgeons from ENT and orthopedics. So on average, we found that telemedicine consultations are suitable for 40% of patients, which is pretty great to reduce unnecessary hospital visits if patients don't have to make a trip there. So the way that I looked at if they're suitable for telemedicine is, if you can see here, either their problem has been solved or a telemedicine follow-up is suitable for them. And the surgeons all filled out this data in the questionnaires. And so that's how we found that 40% of patients are suitable for telemedicine. And so another interesting attribute from this data is that the return to follow-ups have the highest probability of being suitable for a telemedicine consultation. So that's great to keep in mind for us, because the new patients often, as you can see here, 72% of them required an in-person visit. So that was not the most efficient to have them be seen by telemedicine and then as well in person. But here, if you can see, the 17%, their problem was solved by a telemedicine, and then 40% of patients required a telemedicine follow-up. Yes, as you can see there. And so something else, just from the qualitative aspects of the data, we found that phone consultations can be successful to improve support for those with language barriers, as well as people maybe with disabilities who can't leave the hospital, so that would be good for them. And then for the video consultations, we suspected that we would have a lot of issues with connecting to them, but actually only 13%, which is better than we thought for the video consults, were difficult to connect to, but in the end, they ended up working. So there is a bit of a learning curve for surgeons and patients to have that success. And some other things that we looked at were either there is connection issues or poor quality of sound, or that people refused the consultation, but a large part, there were no issues. And so I also wanted to look at, from a study, the perception of the quality of telemedicine before and after the consultation. So before the consultation, 56% of patients thought that telemedicine would be the same or better than an in-person consultation. And after, 69% of patients perceived telemedicine to be the same or better. So it's an increase after they got to experience what a telemedicine consultation was like. So I think that's overall quite positive. And finally, we looked at satisfaction too, and patients were 80% satisfied on average with their telemedicine consultations. So now looking into the results a little bit more for establishing the optimal mix of telemedicine and in-person consultations. So the input variables that I was looking at, as I mentioned before, were ones like age, pre-complexity of assessment, the patient type, gender, spoken language, birth country, education, employment. I also wanted to look at the devices. So if the patients have one or more devices, if they have the number of social media accounts that they use, if they have access to a stable internet connection to facilitate the call, and as well if they have access to a private location where they can feel comfortable taking a call with their surgeon. I also looked at the number of comorbidities, health status, if patients had a hearing impairment or a seeing impairment, and if they were at risk, if they felt that they were at risk for contracting COVID-19 and having a severe reaction. And then finally, the output is the suitability. So are they suitable or not suitable for a telemedicine consultation, which was labeled by the surgeon. So I wanted to do a factor analysis to see the significant factors that are influencing the need for a telemedicine appointment. So I found that above an eigenvalue of 1, that there were 8 different components. So I wanted to look at those a little bit further as strong factors to add to the machine learning models. And so what was found in a rotated component matrix is that the consultation location, having a stable internet location, the education of the patient, and the devices that they own were strongly correlated or significant in driving the need for the suitability of a telemedicine appointment. In future work, I do want to explore possibly removing some of these factors and checking out if others might be more significant so that the surgeon can label these patients' data as future work so that they can either be booked in for a follow-up or a telemedicine follow-up or an in-person follow-up. And for developing the personalized scheduling templates, so these are an example of 2 different surgeons, one in ortho and one in ENT. And so here we have the phone consultation durations. They took about 10 minutes on average for ortho and about 6 minutes or 7 minutes on average for ENT. And here, the pre-consultation, this is the notes that the surgeon has to take to get ready for the consultation with their patients, which has to be factored into the scheduling. And then as well, the consultation is actually when they're meeting with the patient. And then finally, the post-consultation is any notes that they're filling out, requisitions for x-rays or pharmaceutical requisitions, anything like that. And then here for the video, a lot of surgeons thought that the video might take longer, but actually it was 1 to 2 minutes longer to complete on average. And so as you can see, the templates really have to be personalized because this surgeon in orthopedics takes about 11 minutes with their patients, and this ENT surgeon takes about 7 minutes with their patients. So here are a couple figures for the distributions of the consultation time with the same surgeons in ortho and ENT. And so both of those are normally distributed. And I also did an empirical CDF plot to ensure that this normal distribution was a good fit for this data. And then finally, this is a box plot for the pre-consultation, the consultation, and the post-consultation durations. As you can see, that we saw like the pre-consultations, they don't take up too much time, but the post-consultations take up a bit more. And so that has to be factored in when the schedules are being developed, because we can't just look at the consultation time, or else they won't be optimal. And so just a few limitations to go over in the data set. So some of the patients did not complete the REDCap questionnaire after the first one. So that posed a few challenges with missing information. And then there was also a surgeon where they didn't want to do video calls. So the randomization of phone to video call could not be applied and could bring bias into the study. And then there are also times where patients refused a video call when they're assigned to a video call. So that also added some changes. And then the platform that we used was an enterprise Google Workspace platform. And what we found is that if patients were waiting, they would be kicked out of the video call every 10 minutes. So that created quite a few challenges for the patients as well as the surgeons. And for the operations, we've also seen that not all surgeons enjoy using telemedicine. And if we don't have them on board, then the solution won't be able to take place. And there's also no extra administration support to support the setting up of telemedicine appointments. So it could be booking patients or link creations and instructions, things like that currently. And then finally, the MUHC booking software doesn't collect emails right now. So this process must be repeated every time a patient has to see a new clinic and collect that information. And finally, for future work. So in the first objective, where I'm looking at establishing the optimal mix of telemedicine as well as in-person appointments, I will be testing and comparing the accuracy of the machine learning algorithms. So the logistics regression, naive Bayes, decision tree, and support vector machine, as well as exploring removing certain variables from the factor analysis to see what type of results I can get for those variables. And then the second objective, I will be modeling the current situation of the telemedicine space for each surgeon, as well as developing personalized templates, and then testing these templates in the simulation model to determine the optimal one for their practice. And then finally, we are looking at continuing this research and partnering with Swift Medical, which is a wound tracking app. And we're looking to partner with them to support diabetic patients in northern Quebec. And through that, we'll continue collecting data to determine which factors would influence if these diabetic wound patients would be needing an in-person appointment, or if they'd be suitable to be continuing to be seen over telemedicine. And these are my references, and that is it for the presentation.